Okay, good afternoon. I'm going to talk a little bit about a team training that we developed at the University of Washington. We had funding from the Macy Foundation. We had two goals: to teach students how to work together. We were using simulation. The health sciences deans wanted us to pilot something that they could scale up. So we had goals from the institution as well as from the external funders. Oops, went the wrong way right away. Okay. There we go. I wished I could say that early on that we had this checklist, because everything we did around assessment was iterative. We learned as we went along, and we embedded ourselves as the faculty who developed the curriculum as well as the faculty that were evaluating it. And I think that's the sort of the new model in evaluation, the developmental evaluation that you are participating. We came up with the conceptual framework, and I'm glad David spoke first, because we did use the team steps. And we used communication strategies, a few of the strategies, with the students. So we had an activity, we had goals. It was in the simulation lab. We had the objectives. We mapped the competency statements, but it wasn't the United States competencies because they weren't published yet. This grant was funded in 2008 to 2012. But we looked at associated behaviors with a few of the communication strategies that we wanted to teach the students. Simulation can be used for teaching and learning, or it could be used for evaluation. And we are really trying to provide a safe environment for these students to work together, because they had not done that before, and neither had the faculty. So our approach was using simulation as well as team-based care and with a conceptual framework. The participants were not only the students. We had student observers, faculty observers. We were observing the faculty's behavior as well. We spent a year, because this was externally funded, developing the case with students and faculty, learning along the way. So it wasn't something we just put together. We had the case was based on a real case, so we had labs. We had every component that they would normally have in the simulation lab. We also did an orientation to simulation, because not all of our students have access to simulators. And so we wanted to make sure there was an even playing ground. We mapped the curriculum to say, if it's a clinical case, do the students have the same sets of skills? Because if they come in there, they're not at the same level, they will fail. And so for some subjects, that doesn't matter. But if they're delivering care in a high-stakes environment, they need to have the capacity to be able to address a clinical issue, even though our focus was communication. It was not on their clinical skills, because they get that competency assessment within their own professions. And our assessment plan early on was, well, let's just see how well this works. And that was a 4-hour curriculum. I'll go into that a little bit. But it was looking at can we assess the learners for effective communication? But we're also watching faculty, because faculty were the facilitators. So how well did the faculty collaborate as well? And then students were able to provide feedback to each other and to the faculty, and faculty provided to the students. So there was so much assessment going on that it was actually confusing. We used a framework. I won't go into that. It'll save me some time, because David already did. But we focused on communication. There's some specific strategies. And I think this is an evidence-based tool, which is really important. So we didn't just come out of the blue with something. And it's also something our organization is implementing across the system, which is another support for the students. So they hear it not just in these trainings, but they hear it when they're placed within UW Medicine. So our checklist was that what's the goal of the learning activity? It was for pre-licensure students using 3 simulated cases. And we know from the literature that when they do more than one simulation, they get better as well. They start practicing as a team. We had an intermediate outcome, which is really improving their knowledge and skills around the attitude of working together in a team. Again, their first opportunity to do this. And the long-term outcome was to improve communication among and across teams, knowing that this is the most single important patient safety issue, and enhancing teamwork. What we weren't able to do was, does this training in the academic simulation lab, do these skills transfer into practice? That was not our objective. I'll see if I can change this. Here's our curriculum. So we did an online knowledge about team steps, pre and post training. We did an in-person team building exercise, usually with Legos or something that they get together. We set them in interprofessional teams. They come in that way. They introduce themselves. We give them time to get to know each other. And then we did a short, we call it a burst of information on didactic, focused on the communication and the teamwork. And then 3 simulated cases, and it was a 4-hour curriculum. Each time we had a human patient simulator or a standardized actor or both. And then we did a final wrap-up. Okay, slow. These are some of the skills, and we focused just on a few of these. So we spent the year figuring out the case. When would you use an S-bar? Where is a handoff? Or when would the team need to take a huddle based on the case? So it was designed so that those skills had to be practiced, and so that we could evaluate whether or not they learned them early in the training and they could actually demonstrate them. So our assessment plan, as I mentioned, was very complicated and has changed, and it's informed us each year. So we did not come up with something that was static and say, here it is, we'll do some changes in the formative, and then here's the summative evaluation. Yes, it's a great program, and we'll put it out there. What we did was, yes, this works, but we would stop in the middle of the training and say, this is not working. And so we would actually change it, and we would get feedback from the students. We'd do a stop freeze, and then we would continue to do it. So we assessed learners in the middle of it, and we also observed faculty behavior and how they facilitated the clinical case and even the communication with what they wanted the students to do. Faculty could coach students on the clinical aspects, but not the communication piece. And we did this because we wanted them to succeed. We wanted them to provide good care, but the focus was on communication. We had self-evaluation, and we assigned students to be the peer evaluators, and we told them how important their job was going in. And we gave them the objective questions that we wanted them to really see if there was a handoff. Did they do a huddle when they were stuck? Was there a brief when a different group came into the room? Did they feel self-supported? So, and actually the students that started off observing actually performed better at the third one, and we're still doing the data analysis there. They were able, first of all, they knew what we were measuring, but they were also seeing this is important. This particular time there's a handoff, and each case was different as well. We also video recorded it because we have a doctoral student doing her dissertation on the psychometrics of a tool to see, can you measure teamwork within a bunch of individuals who are first learning together? And then faculty got feedback as well. Faculty coached too much or they didn't coach enough, so students were giving us that type of feedback. The program, we did surveys, were completed by everybody, as I said, but the debrief was most important. And now the Canadian competencies, reflection is one of the competencies. And so that's really what you're doing with the debrief. You're having the students talk about how that went, as well as the faculty. So we have multiple tools, surveys, video recordings, self-reports, and then peer reports. And in a debrief, you know that the students right away want to tell you everything they did wrong, but it's a structured debrief where we always say what went well, what could have gone better, as you were saying today, and what's the one thing you would take away from this? What did you learn from this experience? Here's the other issues that I think are important, and I'll be almost finished, is the context. So there's no one tool fits all for IPE. First of all, what are your objectives? What are you trying to teach? And if it's a high-stakes environment, if it's very uncertain and complex, it's going to be different each time you do this. So I think the difficulty here is we think we can measure all IPE, but it really depends on what you're teaching. And there's clarity around the concept. The term itself means many different things to people. So we had to talk about language. We had to talk about definitions, jargon, etc. The strategies were important too to enhance learning. Not everybody has human patient simulators, so we always used actors as well. We wanted the students to have access to both. But the instructional strategies and the design of the unfolding case was important for us. And then the dose and timing. We don't know how much IPE should students get. When should they get it? Early on? All throughout their curriculum? Is once enough? And a lot of that has to do with the individual themselves. They might be the type of person that collaborates well before they even get into medical, nursing, pharmacy, social work school. So how much does the student need? And then leveling the playing field was important. And then the assessment. We did let the students do self-assessment. They got peer assessment, and we did the videotape, so we got a team assessment. So we're still, as I mentioned, crunching the data. But this is very difficult to do. The team might perform well, but there may have been one individual who didn't communicate well. So how do you address that? But that's real life. I'd like to acknowledge my co-PI, Dr. Brian Ross, who participated. And like everybody here, we're part of a greater team that's working on assessment of IPE.